regardless of what an AI optimist you are, and I certainly am, I do believe that the human connection and interaction is critically important and will be for the long term. So it's important for us not to exclusively chase the shiny thing that is AI and emerging technologies. We have to be intentional around what the physical footprint looks like. Hello, and welcome to the Thousand Stories podcast, the relaunch we refer to as the Renaissance series. I'm Justin Brown, former Secretary of Human Services for the state of Oklahoma. When I first launched the Thousand Stories podcast, it was to share the incredible untold stories happening in health and human services, the ones that no one was talking about beyond the challenges and negative headlines. Now, in this Renaissance series, we're stepping into a new era of innovation and transformation, a true rebirth for human services, where we're moving toward a connected, human-centered, and innovative future. Together, we'll explore how leaders, researchers, and practitioners are building systems that truly serve people, illuminating the stories and ideas that define this new era, a renaissance in human services. Welcome to the Thousand Stories podcast, the Renaissance series. I'm joined by my new co-host, Luke Williams. Luke will take a minute to introduce himself in just a moment, but he and I were connected deeply on our passion and mission in serving the health and human services system over the years. He is the president of Tandem Research, a research organization that serves the health and human services system, and a friend. And so, Luke, welcome to the podcast as co-host. Love for you to take a minute and just introduce yourself.
Absolutely. Thank you, Justin. So I'm Luke Williams, president of Tandem Research, and born and raised in Oklahoma City, studied economics in college, and immediately got really fascinated by social welfare systems. I spent 2 years working on that, within the economics department, and then COVID rolled around, and Justin reached out to me, and we knew each other beforehand, and he was like, you've been studying social services and you want a job there. And so I ended up working with Justin for a year back in 2020, went back, completed my degree, went overseas to do a master's in the UK, got pretty familiar with, different ways of doing social services over there, which was fascinating. But I kept working with Justin for 2 years part-time through my master's degree, and now we're working together full time, and couldn't be more excited to be a part of this Renaissance series. Thank you.
Awesome. Thanks for joining me. You and I will have lots of conversations over the years in this series with lots of really interesting folks. The idea here around the Renaissance series really comes from my belief that we are at the dawn of a renaissance in health and human services. I think that we are at this intersection where systems have mostly sort of escaped the grips of a defensive posture from the COVID pandemic. And we've got leaders and agencies and personnel who are battle tested throughout the pandemic. And now they're ready to do the things that they came to these systems to do, to address the big issues in government and in communities through the most important system in America, the health and human services system. And we are also at the dawn of a new set of technology innovations that I think can help to supercharge this renaissance. The idea is now that we can both work to improve service delivery and unlock organizational capacity at the same time through the deployment of artificial intelligence and emerging technologies. So while we're going to talk about that some during the Renaissance series, that will certainly not be the exclusive sort of point of conversation. In fact, today's conversation is much more around physical delivery of health and human services. So that is the intersections and the interactions that occur when human beings reach out for help from human beings who happen to work in health and human services systems. So when people walk into offices, when they interact with community-based organizations, and how we can rethink the delivery model for health and human services through innovations in that space. I talk a lot. Actually, I think it's important for me to sort of frame up a little bit of a narrative. So I talk a lot about the concept of the game Chutes and Ladders. And so when I think about poverty, and really that's what the Health and Human Services system is intended to address, I think about the game Chutes and Ladders. And if you think about that game from our childhood, there are boxes that exist on the game board. And our goal as humans or as players, how about this in the game, is to go from bottom left to top right. That's our goal. And in life, we have lots of goals, but we have our own pathway that we're taking. And our goal is to reach our own definition of success. And in some places, there are ladders that take us up multiple levels on the game board. So in life, those are represented by job opportunities, a marriage, educational attainment, those sorts of things. And then other times there are chutes that we hit that take us down multiple levels, sometimes to the bottom of the game board. In the game of life, those chutes are represented by things like catastrophic health emergencies and a death in the family, a divorce, a job loss, those sorts of things. It's important to note that as you think about this frame, you'll start to come up with concepts that are connected with it. Like, for example, it took me a year to understand that most of those ladders are ladders of our own creation, and most of those chutes are chutes outside of our own control. And so it's important for us to think about the safety net programs that Health and Human Services systems operate as today. I believe that we think of them as almost one-size-fits-all approaches that sit under the game board, and they catch our bodies from physically dying, and they put us back onto the bottom of the game board. They're available to us when we have reached a certain level of despair to reach out and ask for help. The way that we should be building Health and Human Services, and I believe that there are hundreds of people across the country working to develop a system like this, but the safety net ought to be a custom safety net that follows us wherever we go. And so that when we spend our lives sort of reaching space 43 and something occurs, we hit a chute, that the chute doesn't take us down all the way to the bottom of the game board to space 3. It catches us earlier and puts us back onto the game board as high as possible and close to as possible as from where we fell. Why is that important, Luke? I think it's because of a few things. One is it's dignifying. I spent my entire life getting to space 43, and why should I fall all the way down to the bottom of the game board and have poverty, enter my life because of one situation that occurred that was outside of my control? Secondly, it's multi-generational in its impact. My daughter today is her 18th birthday, and her standing on the shoulders of somebody on space 43 puts her in a totally different position for the rest of her life than if she were standing on the shoulders of someone who is on space 3. And then the third is, I think it is better for taxpayers, to be perfectly honest, that providing strategic interventions in families' lives instead of the entire safety net when we've allowed them to fall all the way to the bottom is more advantageous for taxpayers. You can imagine today if someone loses their job and they just need maybe 60 days of childcare, but they don't qualify for it because of the rules of the system, that they could fall all the way down and now have reliance upon all these other programs, when if we had just had the opportunity to provide 60 days of covered childcare so that they could go find a new job, do all the applications, do the interviews without having to worry about the safety of their young children at home because they were in a qualified childcare center. That's an example of a strategic intervention that can be provided. So I think there are a lot of people who say, yes, of course that resonates. Strategic and custom and flexible, nimble safety nets that follow us wherever we go. How do we do that? Well, this conversation is not necessarily around the resources that we provide, SNAP benefits and Medicaid and housing vouchers and childcare subsidy, those sorts of things. This conversation is on the delivery of those resources. I'm a firm believer that I know there's a lot of money in the system, just sometimes there's too much system in the money. And so how do we think about getting those resources and to people when and where they need them earlier before they become in crisis? And that's what I think about when I think about the importance of a delivery model transformation in Health and Human Services. So Luke, I'm going to ask you a question about a recent research study that you all did at Tandem Research around around innovative delivery models. I would love to understand just sort of the process what you thought about how that research went, and then we'll go a little deeper into what you saw across the country that are innovative models for delivery of health and human services.
Yeah, no, absolutely. So we recently developed, this has been about a year and a half in the making, what we're calling a national catalog of delivery model innovations. And so, kind of the starting point for this research was understanding, what is the current state? What does service delivery look like in health and human services right now? And that's remarkably similar across the country. It depends, or it is always kind of a process that requires people to visit an office in person, generally to experience long wait times, often not have their questions answered or their needs met because there's, not always a warm handoff when someone walks in the office. They can't always express their needs very well. Maybe the worker isn't super qualified to kind of identify what their needs are. There could be a lot of friction in that kind of first interaction. Even just navigating an office, sometimes old government buildings can be difficult. And then, from then on, once someone is, once the uptake process has been worked through, a lot more of the service delivery depends on receiving items in the mail, mailing items back to the office, going back to the office for an interview. There's a lot of steps that, there's just moments of friction when people can fall out of the system or forget to mail something in. It's really easy to lose people in that process, or even just to scare them off. And so, understanding that that's kind of the current state of things. At Tandem Research, what we did is we spent a few months doing a very large scale search of, going state by state, seeing what we can find online about how states are thinking about doing this differently. And we think of what is service delivery. Service delivery is identifying people who are eligible for services, right? They meet some set of criteria, whether it's income or work, or lack of work. They meet some set of criteria that make them eligible for services. We need to identify who those people are, and then we need to get them enrolled, and we need to get them services. And there's a million different ways that you can do that. And states are being incredibly creative right now about going out in the field and finding people in rural communities, or doing a lot more reaching out over the phone or through community partnerships. But so what we did was we were looking for these kind of innovations, one state at a time. What can we find online? If we can find something interesting but incomplete, we're going to call up a stakeholder in that state's agency, and we're going to interview them. We're going to look for any research that has already been done on innovations, and we're going to kind of pull from that. And what we've produced, and again, I mean, we've been building it for a year and 2 months, and we'll continue to build it and update it. But it now is a full catalog of, I think it's 46 different innovations covering over 38 states, I believe. 20,000 words, telling the stories of how states everywhere have changed the game in getting services to people.
I love it so much. So you mentioned a few barriers that exist, and I thought about this all the time at DHS in Oklahoma. We built a process called Finding Our True North, and part of that process included building from the grassroots, from the ground up, talk to thousands of employees through surveys and interviews and just one-on-one conversations. We built a set of core principles that we worked through, and it really guided all of our work at DHS in Oklahoma. And some of those core principles were the reason that we created a new delivery model for health and for human services at DHS. So I thought I would elevate a couple of those. And the first one, as you were talking about barriers, was all around barriers. It was our desire to remove systemic barriers to keep our customers from accessing resources. And so you mentioned some of them. Those are barriers around language, around transportation, workforce barrier. I mean, we require people to come to offices, but we also first require and hope that they're working. And so how do you do that when you're working and you have to take time off? You have children, and so there's childcare barriers. There's also a barrier that maybe over time we talk about more, but is the barrier of stigma. Health and Human Services agencies over the generations have built a pretty poor reputation in community, many times justified, I believe. So how do we think about over time starting to remove the barrier of stigma and build trust between systems and people? So that's a huge conversation for another time. So that was one of them, was removing systemic barriers to keep our customers from accessing resources. We also wanted to move upstream to a more preventative posture. And the idea was, if we can meet people before they become in crisis, then we've positioned our agency in the right way. In Oklahoma, we get about 80,000 calls a year to the Child Abuse and Neglect Hotline. And that is a symptom of the issue where we are meeting people later. They have fallen to a level of despair where now they're engaged in much deeper rights impacting systems like child welfare. And in reality, we should be meeting them earlier in the poverty fighting systems, because it's important to note that of those 80,000 calls a year, 90% of them are neglect and not abuse, and 70% of those are related to poverty. So 63% of those calls are poverty related. And so if we can move upstream and meet them in systems that are much less intrusive into families, we can prevent them from ever falling into systems like child welfare. And so anyways, that was another True North principle that really allowed us to the flexibility when the pandemic hit to think about, and the motivation to think about a new delivery model. So a lot of this work that you're doing identified some things that happened in Oklahoma. We don't have to talk about those things. In fact, I'd probably prefer not to. I can answer those questions on the outside, because this is not an Oklahoma DHS commercial. This is a Health and Human Services National Innovation Model conversation. But I'd love your thoughts on, as you sort of surveyed all those, like you said, something like 48 different programs in 30 different state agencies, like what were the common themes? I know there were some categories, so you might sort of walk through what those categories were, and then maybe we'll talk about some specific programs as well that were of particular interest.
Yeah, no, of course. So we developed 8 categories, and this was very much, post hoc, right? We had this set of examples. I think our first set of examples were 20 different cases, right, of innovation, and it was a process of looking at these 20 different cases and trying to identify, essential kind of through lines that made them different from each other, right? And now that we have over double the amount of cases that we started with, we've had to add some categories in. I think we started with 5, now we're at 8. But we've essentially identified 8 different categories of delivery model innovation. Just to kind of walk through those really quickly, and I'll give a brief explainer for each. The first one is the broad term we use for it is just community partnerships, right? And there are different levels of this. Each category kind of has its own subcategories. But you and I can talk more about that in a bit. But community partnerships at bottom are when services are delivered through usually formal partnerships with local nonprofits, right? And that can be kind of a thin partnership, which would be embedded workers, or it can be a really thick partnership. I mean, on the complete other end of the spectrum, in Nevada, some nonprofit workers in very rural communities are actually licensed to take people in the nonprofit space through the entire SNAP application process, right? And those are not employees of the state. They're not employees of the HHS agency, but it's nonprofit workers doing the work of an HHS worker.
Yeah, and by the way, real quick, Luke, those listening will have enough understanding to know that in that model and all others, those people can't actually execute on eligibility determination that requires a merit protected employee. But in that model, the worker at the community-based organization essentially proxied that application all the way through to allow the agency to then execute on eligibility determination. Just a point of distinction, we have some discerning listeners who will know that we missed something there. So anyway, sorry to interrupt.
I mean, it is surprisingly thick, though. They're licensed to do interviews as well, I think, which is not seen anywhere else in the country. No, please interrupt. I am not as discerning as you are.
No.
So the second category that we have developed is co-location, and I think that there's the boundary between a community partnership and a co-location is slippery, but the way that we think about it is community partnerships is to some extent, an internal team partnering with an external team, right? And that could be, generally it's going to be a partnership with a nonprofit. It could be a partnership with a private sector firm as well. Or even a university, we might say. Co-location is more a public-public partnership, right? And that's, I mean, the standard example here is the one-stop shop model. which is kind of one of the earliest delivery model innovations that you can really find. It's becoming less popular. The third category that we have is real estate modernization. That's Justin, that's your wheelhouse. That's what you did in Oklahoma. San Diego, we don't have to talk about
Yeah,
Oklahoma. San Diego has done some pretty remarkable
they have
real
for
estate
sure.
modernization as well. And what that entails is generally the essential quality of it, the essential characteristic is um, a strategic slimming down of office space to allocate. So it's usually removing old or shuttering old office buildings that had, a large administrative teams on site with frontline workers, on site with child welfare teams all together, right? And it's usually not, but not always, completely kind of abandoning that space, allowing administrative workers to do a lot of their work remotely, and then opening kind of more strategic, targeted, smaller offices. Some for intake, right? Like simply for getting people into programs. Some for so like San Diego has triage offices that actually have in-person administrators just to do very quick case management items. So someone will come in and say, I lost my job. Yeah, I've gotten a raise. I need to change my marital status. And, they can do that at that office. Um, or building offices dedicated to child welfare. That's another example of real estate modernization.
Yeah, I think this
Um,
one is really interesting because so many people think about government health and human services as physical locations. And I know that in a decade or whatever the time frame is, physical buildings will look completely different or may not exist. I mean, we don't know because of technology implementations, but um, it is today, and I think for the foreseeable future, there will always be a need for a place for a human to interact with a human in these difficult programs. And so this is an opportunity, this real estate modernization category is for us to rethink what that looks like. We don't need all of the administrative space that we needed before, and that's a lot of the experience that we had in Oklahoma. Many people know this, but I closed, or we during my time closed 41 out of 92 offices, more than 1 million square feet, millions and millions of dollars of expense that was underutilized, dramatically underutilized. Health and human services is a field-based system generally. So we had employees who had office space that were never there because they were always meeting families somewhere. They were always out in the field. So we had an opportunity to harvest savings and real estate, but improve our level of service. I have really great stories that I can tell about this, but we were instead of like leaving, so we closed a building. Instead of leaving a community, we would actually go deeper in a community with an embedded workforce. And it's important to note that you're going to lay out these 8 categories. You're through 3 of them, I think, but there's a lot of overlap and synergies between
yeah.
some of these together. So it's not just individual isolated approaches and strategies. It's pairing real estate modernization and streamlining footprint with an embedded worker approach that really improves service, because the desire again was to remove systemic barriers, meet people in community rather than forcing them to fall to this level of despair to come reach out to ask for help in person. Meeting them there, removing barriers, partnering with organizations to improve resource procurement. So anyways, I just thought I would throw that in there, that there's just such an alignment between some of these as a more comprehensive approach.
Oh yeah, no, I mean they complement each other all the time. I think going off of what you're saying, it's pretty clear after, you look on this survey, most of the innovations that we've identified happened in the last 5 years, really, since 2020. And I mean that COVID was such a spark. And it
Yep.
seems like the push toward the future in health and human services is really, it's exactly what you said. It's getting people, getting HHS workers more in the community, right? That's real estate modernization can do that. Community partnerships are a very clear way of doing that. The fourth category that we've developed can do this as well, quite successfully. That would be mobile service delivery. And that's not mobile like your phone. It's mobile usually in a large Greyhound bus or a van, or even in a semi-truck trailer. And what that means is, so this is increasingly, it's getting popular, but there's still just a few examples of it. Um, but so the kind of intense example here is that you take a Greyhound bus, you gut it, and you build 6 office stations, right? You have a bathroom, you have a meeting room for private interviews, you have Wi-Fi, air conditioning, 6, like I said, like desks essentially. And you can drive this bus around into rural communities, into disaster areas, and the bus is staffed by usually specialized teams trained to do intake and eligibility determinations for all self-sufficiency programs. And they are dedicated to the mobile unit. Um, and so, the certain jurisdictions have used this again to really focus on serving rural communities, to focus on disaster relief. It's also been used to alleviate burden for overburdened offices, right? When a certain physical office has a really high caseload that's so much larger than its neighbor, the agency will dispatch the mobile unit to assist that office for a week or so. Sometimes they could be rented out and put in the middle of a community event like a nonprofit barbecue. And they can sign up people there. They're usually equipped to print out EBT cards, so it can be really snappy and effective.
Oh, I like the pun there, Luke. Snappy with EBT cards. That's only a joke that our HHS friends who are listening will understand. EBT and Snap. That was good. Another thing, so when you talk about those mobile opportunities, is we used to also pair them with other organizations who had mobile buses as well. So Oklahoma City County Health Department for immunizations and well child checks and that kind of stuff. And so we would plan events together where we knew there would be, a lot of folks who really needed to leverage some of our services together because we served the same people. And so it was really an exciting opportunity to sit alongside a partner who had shared mission and build relationship with that other organization and connective tissue while serving people together.
Yeah, no, absolutely. So in terms of physical delivery model innovations, those are kind of the big 4 categories that we're seeing today. Community partnerships, and kind of the physical element there. I didn't cover this, but when we're talking community partnerships, you have embedded workers kind of on the thinner end. You have licensing nonprofit workers on the thicker end. Only Nevada's gone that far. And then in the middle, and this is kind of I think a quite innovative space at the moment, is building shared physical office space, right? Where the nonprofit will co-locate with HHS employees or employees of other government agencies. Oklahoma and the Hope Center is at the forefront of that. But yeah, so these 4 categories: community partnerships, co-location, real estate modernization, and mobile service delivery. Those are the big physical ones. The other 4 categories I'll just kind of briefly gloss. They're not physical delivery transformations. But what we have is number 5, intensive case management, which is in some ways an old hand in social services delivery innovation. It means giving caseworkers the tools to develop career pathways with people that they're serving, or educational plans. It means focusing on expanding what service delivery means by being able to envision a future constructively with somebody, to refer them to resources more adeptly. So that's kind of our 5th category, and there's some good, interesting things happening there. The 6th is integrated online portals, and for our listeners, I'm certain you all know what that is. But there's also, this is another thing that I think we all think is quite common in health and human services, but there are interesting things happening, especially with AI and integrated portals, where Minnesota, for instance, is it Minnesota? Yeah, it's Minnesota, I believe. Has an online portal that does intake for every single service. And they use robotic processing, RPA, to instantly update, that customer's information across every, server in the HHS agency. They can also identify more proactively, what that customer might be eligible for, in a different program or even in a different state agency. So there's some interesting things happening there. The 7th category of innovation is the modernized contact center. That again has to do a lot with AI at the moment because contact centers aren't new. But a lot of the push there is using AI to kind of serve as like a front man, right? When you call the contact center, you speak with an AI. It asks you kind of a set of questions with conditional logic, and it determines, this is where I'm going to pass you off to a human, right? So we have a contact center team for SNAP. We have a contact center team for updating case information, right? For Medicaid. And the AI essentially does the work of a director, like a directory. That's kind of the
Like a
main push
switchboard,
there.
sort of like a switchboard.
Yeah, switchboard
Yeah.
operator. I think that's a good way to think about it. There's also, I mean, there's some interesting like consolidation, like in Florida. I think some states it was common to have contact centers for different areas, or even almost like one contact center per office. And states are getting very creative with creating just one statewide contact center that services everything. And that's seen some pretty good success. And then the last category that we have is just very broadly tech-driven case management. This can look a million different ways. California is a leader here. And essentially, it's just using emerging technologies like AI to analyze customers' case information and their data. Mostly pushing toward either detecting fraud, but that's not quite service delivery, or developing what California calls predictive capabilities, right? And they're still working on this. It's not in final form yet. But the idea is that if you use AI to track case updates and case information closely enough, you might be able to tell when somebody is about to have a medical issue, right? You might be able to tell when someone might lose their job or get a raise. Essentially, when some life event occurs that will change the nature of the services that this person is eligible for or not eligible for, and then the state can be a lot more proactive about either preventing something bad or helping foster something good.
Well, it's all about the idea of moving upstream, and technology can allow for us to do that. We don't have the capacity in these teams today to really move to a prevention posture in all of these systems. But for those who are unclear on the concept of moving upstream, I'll share a quick anecdote. The idea is that if you can envision yourself walking alongside a river, it's a beautiful day, but all of a sudden you see a child floating down the river in peril, and you wade out and you yell at other bystanders and you pull that child into to the shore and save that child's life. And then you see another one coming, and the human chain gets that child, and then they start coming more rapidly. And you see a person, just one of the members of the chain, just take off running upstream, and yell, "Hey, we need your help. I'm pulling these kids out of the river." And he said, "Well, I'm going up there to figure out who's throwing the kids in the river." And so that's the idea, is running up the river to see what the cause of this issue is, and moving upstream. And states have not had the ability to do that in any meaningful way, because the typical worker in these programs have something like 800 people on their caseloads across the country. And so they are purely transactional in their approaches today. And the desire is for them to become relational. It requires capacity. And so I know we started off by talking about the idea that we're not going to always talk about AI and technology. In fact, most of this conversation has been around physical delivery model transformations. But it is important for us to know and to think about and to likely embrace the concept that for us as systems to change, to truly change the direction of our systems, it requires contemporary technology, so that we can move upstream, that we can get client or workers closer to clients in a systemic fashion, where we can do automated case management, so that those people who are working 800 cases at any one time can be freed up to work the complex cases, not the sort of standard run-of-the-mill cases that can be served by either self-service portals or AI or whatever. So anyways, technology is a critical component to a future delivery model for health and human services. So anyways, again, sorry to interrupt. What other thoughts do you have?
That's all. I mean, I think we can return to talking about buildings. I know you like buildings.
I do like buildings a lot. Thank you for saying that. So yeah, honestly, what I would like to share, I think, as we wrap up, is I do think, and I've already mentioned this, that the physical in-person experience is critical in health and human services, and it will be around for the foreseeable future, regardless of what an AI optimist you are, and I certainly am. I do believe that the human connection and interaction is critically important. It will be for the long term. So it's important for us not to exclusively chase the shiny thing that is AI and emerging technologies. We have to be intentional around what the physical footprint looks like. And so, just as we close, I'll share. How about this? I'll share a story. Um, I'll never forget. So we had an office in Tulsa at the Department of Human Services. It was huge, well over 100,000 square feet. I want to say it was like 250,000 square feet. It's massive, downtown Tulsa. And it was, no offense to anybody who worked there. Had been there many times. It was depressing to go into, and it looked similar in finish to all the other of the 92 buildings that we operated at DHS. I refer to them as dinosaur buildings, and in many of these buildings, they hadn't been touched since 1992. There were stories. Many people will chuckle about this because they'll remember me talking about it when I was leading the agency. But stories of snakes coming out of ceiling tiles. Just terrible circumstances, and physical environment. The built environment really articulates to our workforce and the people we serve how we value them. And so it was critical for us to truly transform those spaces. We went deep into the real estate modernization and embedded worker strategy, and we actually closed that building at the request of a local university who was wanting to build a downtown Tulsa veterans mental health hospital. An incredible purpose. We were honored to be able to provide that building. We just gave it over to, it's state tax dollars, so we just handed it over to this other agency. And I understand that facility is going well. Anyways, we closed that huge building downtown, and you would anticipate that there would be service disruptions in Oklahoma's second largest city. But what we had done is we built a small 3,000 square foot space in downtown Tulsa that was made to look like an Apple Genius bar. It looked great. Big windows, lots of natural light. No barriers between the clients and the people serving them, the incredible service of the Department of Human Services. And in prior times, when I'd gone into the big building, every time you go to the lobby, there were 70 people lining this lobby, waiting to see somebody, kids crying. It was just a terrible circumstance. The workforce hated it. Everybody hated it. And I remember after we closed that and I went to this smaller space, just 3,000 square feet, with 19 interview rooms. I remember walking around talking to the team for a while, maybe an hour, and I realized that only two clients had been in that space in the hour that I was there, and in the prior space there would have been 100 easily. And I was a little concerned about that, and so I asked, why is nobody here? If this were the other building, there would have been 100 people here. And the young lady on the other side of the desk said, Justin, I think it's because we now have 12 partner locations within a mile of this location. And we are meeting people in those spaces rather than meeting them here. They don't have to, I used this term already too much, fall to this level of despair to go into DHS to ask for help. We're meeting them in their community where they are. And so that was a really incredible illustration for me as to how this can work and that it does work. And we saved, I don't know, many hundreds of thousands of dollars a year on real estate by just taking our workforce and distributing them to community partners in Tulsa, and had a much better level of service. So that's what comes to mind for me. And then I don't know whether this is not relevant to share, but there's sort of a wrap story here for me that that same visit, I remember a young kid, probably 19 or so years old, riding his bike. He was certainly experiencing something, but riding a bike sort of around the windows. He would pass by and then a few minutes later pass by again. And eventually he stopped the bike, parked the bike, came into the office and went to the desk, and there was nobody else there. So it wasn't like a huge line or anything like that. He just went to go ask a question, and I didn't hear all the conversation, but about, 20 minutes later, I remember him putting his sort of hands or his head in his hands and crying, weeping, and saying, I had $2 left in my pocket. And that's all that I have in this entire world. And our worker, we had an EBT card there, had just given him the EBT card. It took 30 minutes for him to get walk in, ask the question for the first time, get an EBT card, and leave with I don't know what the benefits were on that card, but enough where he could eat. And it was just an incredibly powerful experience, not related to the delivery model transformation, which is why I'm not sure it was all that relevant. But at the same time, it's important to point out for those who are listening that are not a part of the Health and Human Services system, maybe you're learning about it or you work for a vendor and you're thinking about delivery model transformation, that these systems matter, and that this is where, I think I mentioned earlier, where government meets human beings in the most vulnerable of their times. And the people who work in these systems deserve technology, they deserve spaces that validate what we think about them and how much we value them. And so anyways, I thought that was a sort of impromptu but meaningful way to end the conversation today.
Yeah, I mean, at the end of the day, you have to remember the stakes of this are really high, right? It's work that you want to do well.
Exactly.
Can I ask you before we wrap?
Yeah.
I want you to dream with me for a second. So we have these four kind of physical delivery model categories, right? Community partnerships, co-location, real estate modernization, mobile service delivery. You've already touched on the fact that these can mix really well, right? And that even, in Tulsa there, it sounds like you were doing real estate modernization paired with, right, embedded workers, community partnerships. How do you see kind of the balance playing out? If you're a leader in health and human services right now, thinking about innovating, of course it's going to change given your context and what state you're in and what the needs are. But do you think that kind of these three, so community partnerships, real estate modernization, and mobile service delivery, do you think you would almost always kind of do a mix of them, or do they have really different needs? How would you think about balancing these things?
Look, that is such a good question. I think physical spaces should be purpose built. And so we are moving away from sort of comprehensive buildings where you have huge administrative areas and you have a lobby and you do some child welfare work and maybe seniors come in for whatever, like that's not efficient. And generally those are built outside of high traffic areas where people would come anyways. I mean, I'm sorry, people don't want to go to a DHS. I mean, as much as we love these systems, there's just, the trust isn't there. The trust is built in community partners with community-based organizations. That's community action agencies and federally qualified health centers and boys and girls clubs and YMCAs and schools and hospitals and those sorts of things. And so I think a distributed model where service needs are met in community partners is the preference, and physical real estate is built for purpose. And what I mean by that is these are huge workforces, so you need a place to do administrative functions. They can be geographically proximate to people, but you don't need one in every county. But it's a place for team meetings and potlucks and HR sort of things and hiring and training and that kind of stuff. But it should be built for that purpose. Spaces for, you mentioned it, the child welfare system, where there is incredible complexity, where the trauma is deep and real. Those places should be built to accommodate those needs. Specifically in Oklahoma, we did do a whole bunch of that work in freestanding child welfare standalone spaces where, in the middle, it helped to serve middle of the night work. So, if it's 11 o'clock at night and you're a worker and you just made a really hard decision and, you've got a child in your car and you need somewhere safe to go, like in the middle of the night to help make foster care placement, there's somewhere safe there where the child can come in and, you can do lice treatments in like an actual hair wash station instead of a sink of a county office. And there's laundry facilities or what, like stuff, things that are put there to actually serve that person.
video game stations,
Of course,
bunk beds that
we want to
no.
stay away a little bit from sleeping in places. There's some, it's okay. I mean, honestly,
that was my mistake.
These are definitely not shelters. We're not talking about building shelters.
Well, I was trying to remember, maybe it was a conversation with a community nonprofit perhaps, but this was forever ago, back when we first started the survey. We spoke with an office, and I can't remember what office it was, but it was an office that had built community child welfare spaces that served different functions for child welfare, right? So you had a child welfare administrative space, you had a child welfare kind of where the frontline workers could house all of their
visitations.
Resources.
I mean, specifically designed for visitations, super important. Yep.
And I think that they had partnered with, because I distinctly remember having this conversation. I think that they had partnered with a community nonprofit or something. I don't know.
Yeah, well, hey, listen, it's logical that those sorts of things would exist. At the same time, it is a really slippery slope when we moving towards shelter, and that is a system that agencies are trying to move away from for a whole lot of reasons. And so, anyways, the idea is purpose built for complex situations. Child welfare is certainly one of those things. And so I do think the answer to your question is a meaningful but intentional mix of community-based organizations with embedded workforce and empowered to do the work. I do think, I mean, there are social workers all over this country that if we just gave them the ability to actually execute on some of our programs, they could help us be much more timely and much more supportive of those that we serve. But buildings should be purpose-built and intentional as well. That just creates efficiency opportunities across government. So it's a huge future. The opportunities are endless in transformation. I think you all did a great job at Tandem on this delivery model sort of landscape assessment of innovative models. I know that you will keep working on it as opportunities arise, and we'll keep that model up because one thing we know in innovation is it's never static. And so, Luke, thanks for joining me today as my co-host on the 1,000 Stories podcast, the Renaissance series. I'm excited about doing this with you more and more. And we'll be in touch with our listeners the next time.
Absolutely. Thank you, Justin.